In this video, we are going to be moving out from the central nervous system to the peripheral nervous system and start talking about nerves. Specifically, we will be talking about cranial nerves. So this is where we are in this diagram. So the central nervous system is going to receive input from the sensory division of the peripheral nervous system and send information out to the periphery via or send information out to the motor division of the peripheral nervous system. But before we talk about cranial nerves, let's take a step back and talk about nerve structure. So nerves are going to be bundles of axons in the peripheral nervous system. In the central nervous system, we refer to those as tracts. You have sensory or afferent, which carry impulses only towards the central nervous system. You have motor or efferent, which carry impulses away from the central nervous system. But then you do have some nerves that are mixed, that are going to transmit impulses to and from the central nervous system. You can see the nerve structure is going to be kind of similar to muscle structure in that you're going to have an epineurium that surrounds the overall nerve that then is going to be bundled into fascicles, which are going to be surrounded by the perineurium. And then the perineurium is going to have the actual axons in there with the endoneurium surrounding them, with the axons themselves being covered by the myelin sheath. All right, so let's take a look at the cranial nerves. Cranial nerves are numbered 1 through 12 Roman numerali. Mostly they are going to be numbered going more, starting more anteriorly and moving more posteriorly, and increasing in number. Other than the vagus nerve, which extends to the abdomen, cranial nerves are going to serve only head and neck structures. So we have number 1 being the olfactory nerve, 2 being the optic, 3 oculomotor, 4 trochlear, 5 trigeminal, 6 abducens, 7 facial, 8 vestibulocochlear, 9 glossopharyngeal, 10 vagus, 11 accessory, and 12 hypoglossal. Now, it's kind of hard to remember all of those things, so here's a mnemonic that I put together to maybe help you remember this. So the mnemonic is: old opossums occasionally tromp triumphantly about, fanning very glitterly vampires, acting like hypochondriacs. And then I have this little video or little image that is next to it to help illustrate that. So you have these opossums, they kind of have a beard, so they're old opossums. Occasionally, so not all the time, we have a calendar here showing February 29th, so leap years, that's occasionally. Tromp, you can see they're stamping their feet. Triumphantly, they have a trophy, so that clearly they have been triumphant, and they're tromping about. Fanning, so they have a fan, and these vampires over here, they're clearly very glittery vampires. Maybe they're from Twilight, which had sparkly vampires. But you can see these vampires are acting like hypochondriacs because they are putting band-aids all over themselves. So that's a little mnemonic to hopefully help you remember the order of them. As far as remembering whether the nerves are sensory, motor, or mixed, also both, we have this mnemonic: some say marry money, but my big sis believes brains matter more. So you can line these up with the different nerves. So 1, 2, they're both sensory. Marry, money, these are both motor. But, that's both my motor, big, both, cis, sensory, believes, brains. So those are two, both, matter, more, mixed for the cranial nerves, um, 11 and 12. All right, so let's get into what the different cranial nerves actually do. So let's start with the olfactory nerve. So this is purely a sensory. It's going to be involved in smell. To test it, you could sniff and identify different aromatic substances. Fracture of the ethmoid board or lesions of olfactory fibers may result in anosmia, which is going to be the absence of smell. The optic is purely sensory as well. Testing, you can access the visual field and vision with an eye chart. And then you can use an ophthalmoscope to detect swelling of the optic disc. Damage is going to lead to anopsias. Before the optic chiasma, you have blindness to the eye, and after the optic chiasma, you have partial vision loss. So it all matters where it is going to be damaged. So we have your optic disc right here. So the retina sends information to the optic disc. You move via your optic nerve. At the optic chiasma, it's going to enter into the cranial cavity and the brain, and thus be considered a tract from here on out. So it becomes a tract, and then you have it moving back through the geniculate nucleus of the thalamus to the occipital lobe of the brain, where you ultimately are going to receive that information. So notice that your visual field, the lateral portion of your visual field is going to be connected to the opposite side of your brain, but the more narrow region here is going to be connected to the same side of your brain. So you can see green here staying on this side of the brain, green over here going to the other side. So laterally, flip sides, medially, it stays on that same side of the brain. The oculomotor nerve is chiefly motor and concerned with most eye motion. So superior, medial, inferior rectus, and inferior oblique help with the direction of eyeball movement. In addition to that, there are other muscles like the levator palpebrae superioris that helps to raise the eyelid. The sphincter pupillae is going to cause the pupils to contract, and the ciliary muscle, which controls the lens shape. You can test this by examining pupils for size, shape, and equality. You can test the pupillary reflex with penlight, test convergence for near vision, and subjects' ability to follow an object with their eyes. The trochlear is chiefly motor. It is also going to play a role in eye motion. It is going to connect to the superior oblique, which helps to direct the eyeball. So you can see the superior oblique muscle or connecting through here on the brain. So it's going to be contralateral, meaning it's going to direct the opposite side. The trigeminal nerve is both motor and sensory, so it's a both one. So you have three divisions. The ophthalmic is going to connect in via the superior orbital fissure. The maxillary region is going to connect to the pons via the foramen rotundum, and the mandibular via the foramen ovale. The function, so the ophthalmic is going to be sensory from the upper face, the maxillary from the middle face, and the mandibular from the lower face. Testing, you can use the corneal reflex test to test the ophthalmic division. The maxillary, you test sensations of pain, touch, and temperature, and mandibular. In addition to that, you have to, in addition to the sensations, you're also going to be accessing motor skills. Abducens is chiefly motor. It's involved with eye motion. It's going to control the lateral motion, rectus, which is going to help direct eyeball movement. Testing is going to coincide with cranial nerve 3, since you're looking at an ability to follow an object with the eyes when you're testing for it. 3, 4, and 6, because they are going to be involved with movement, they are going to be related to one another. So if you have oculomotor nerve paralysis, eyes cannot be moved up, down, or inward. Thus, at rest, the eye will rotate laterally. The upper eyelid droops, the person has double vision and trouble focusing on close objects. Damage to the trochlear nerve is going to result in double vision and impairs your ability to rotate inferior laterally. And then in abducens nerve paralysis, the eye cannot be moved laterally, and then at rest, the eyeball will rotate medially. So you can kind of see some different ways that the eyes would move depending on whether you have damage to one nerve, both nerves, and which nerve associated with it. The facial nerve is a mixed nerve with both motor and sensory. It helps to convey motor impulses to the muscles involved in facial expression. It also helps transmit autonomic motor impulses to the lacrimal, nasal, and palatine glands, and the submandibular and sublingual salivary glands. Sensory input from the taste buds of the anterior 2/3 of the tongue also come from this region. Testing, so the anterior 2/3 of tongue test for sweet, salty, sour, and bitter. You'll check for asymmetry check for the symmetry of the face and facial expressions, and you look to see if you can cause tearing using something like ammonia smell. Bell's palsy is an example of something that can go wrong with the facial nerve. So it's caused by a swollen and inflamed facial nerve, which causes paralysis of facial muscles on the affected side and partial loss of taste. All right, the vestibulocochlear nerve is mostly sensory. It has two divisions: the vestibular division, which is going to transmit impulses for equilibrium, and the cochlear division, which is going to transmit impulses for hearing. For testing, you're going to check the hearing and check bone conduction using a tuning fork. The glossopharyngeal, this is mixed. It contains motor fibers that control the muscles involved in elevating the pharynx while swallowing, and parasympathetic motor fibers that go to the parotid salivary glands. Sensory fibers conduct taste and general sensory impulses from the pharynx to posterior tongue. Chemoreceptors that monitor O2 and CO2 from the carotid artery, and baroreceptors, which monitor blood pressure, are also found in the carotid sinus. So testing, you look for the position of the uvula. If it's damaged, if the glossopharyngeal is damaged, it will tend to lead to one side. You also are going to check the gag and swallowing reflexes and check the posterior third of the tongue for taste. The vagus nerve is mixed. Its motor fibers are mostly parasympathetic efferents, but it also serves skeletal muscles of the pharynx and the larynx. The sensory fibers from it transmit impulses from the thoracic and abdominal viscera, and then other baroreceptors and aortic bodies, taste buds on the larynx. Test this one with cranial nerve 9. And finally, the accessory is primarily motor. It controls motor fibers that control the sternocleidomastoid and trapezius. So these are going to be upper back muscles / neck muscles that are going to control your ability to rotate your head and shrug your shoulders against resistance. When you have damage to this, it might result in winging, which is what is going on here with the scapula. The hypoglossal nerve is primarily motor. It controls tongue movements. Asks an individual to protrude and retract their tongue and note any deviations in position like you would see here. All right, so that was the cranial nerves. In our next lecture, we'll talk about the spinal cords and spinal nerves. I'll see you then.